Thank you so much for joining us on what's still a lovely evening for our May webinar on the topic of pharmacists in addiction services, the importance of working together. Before I introduce our guest speakers, I'd like to start with a land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawenderons, and is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So thank you for joining us from wherever you are. I'm pleased to introduce our presenters tonight, Beth Sproule and Chong. Beth is a clinician scientist at the Centre for Addiction and Mental Health in Toronto, jointly with the Leslie Dan Faculty of Pharmacy at the University of Toronto, where she is an associate professor, cross-appointed to the Department of Psychiatry. Beth received her Doctor of Pharmacy degree from Wayne State University in Detroit and her BSc Pharm degree from the University of Toronto. She completed a clinical residency and a postdoctoral research fellowship at the Addiction Research Foundation, when it was the Addiction Research Foundation, now part of CAMH. She has worked in community and hospital pharmacy. Her clinical research program focuses on addictions, mental health medications, and pharmacy practice. And I'm sure I'm not alone in remembering the Addiction Research Foundation. Although we may be a shrinking group. Chong is a community pharmacist and managing partner at Moss Park Pharmacy, an independent pharmacy in Toronto. He received his Bachelor of Science in Pharmacy and Doctor of Pharmacy degrees from the University of Toronto and his Master of Health Informatics degree from the University of Waterloo. Kenny has taught as a clinical lecturer for the Leslie Dan Faculty of Pharmacy at the University of Toronto, and he and his pharmacy team provide a variety of primary care and addiction-related services to their local community. So we're so lucky to have you bring your expertise and perspectives from both the community and academic settings to really talk about what collaboration can look like in the care of people with addictions and substance use disorders.
Thanks for having me.
Okay, thank you. So we'll get started. Thanks, everybody. Thanks for the introductions, and thank you for joining us tonight. Kenny and I will be sort of going back and forth with the slides as we go through the presentation. And then we're looking forward to the discussion at the end. So we're really pleased to have been invited to do this talk, as well as we welcome the opportunity to kind of speak about pharmacy practice in addiction services in particular. As you may have seen, the learning objectives, that what we hope is that we'll bring some understanding to the scope of pharmacist roles across addiction treatment settings, to help recognize the value of collaboration to support patient care, as well as identify actions that can help interprofessional collaboration. So in this presentation, what we're going to do is have a bit of an introduction to pharmacy practice across settings as it relates to addiction services. Most of the talk will focus on community pharmacy practice, and as well as sort of looking at some of the barriers in that setting around providing sort of the best care that we would like to. Then we're going to focus on particularly the value of collaboration in the care of people with opioid use disorder in particular, as well as actions that can help with fostering collaboration. And then we'll finish with a discussion at the end. So just this slide is just kind of showing an overview of pharmacy practice settings. On the left, you'll see community pharmacies, which is the sort of one that I think most people think about when they think about pharmacists and pharmacy practice. And in community pharmacies, the pharmacists provide clinical services that are usually tied to providing a product, so dispensing a medication. The things we wanted to emphasize from the outset in talking about these different settings is that in community pharmacies in particular, for the most part, the records, patient records, are sort of very separate from other records in the healthcare system. Pharmacies do have some connection with the narcotics monitoring system with respect to alerts that they receive as they're dispensing controlled drugs, as well as Ontario Drug Benefit alerts. But few actually have access to portals such as Connecting Ontario or Clinical Connect, depending where in Ontario. Whereas in hospitals, pharmacists also provide clinical services, and obviously we also provide medication and take over the prescribing, all the prescribing and dispensing of their medications during an inpatient stay. But in this setting, pharmacists are integrated members of the interprofessional team and have access to the same health records during the hospital admission. There's also pharmacists who are involved in outpatient clinics or teams, for example, family health teams or outpatient clinics that are associated with hospitals, for example, where primarily their service is clinical, not associated with actually dispensing medication. But in that setting, they're also members of an interprofessional team and have access to the integrated health records, which this sort of emphasizing this access to health records as a sort of a prelude to our focus on communication and information in this, information sharing in this talk. So within each of these settings, you can have pharmacists that are practicing within sort of an addiction specialty setting. So I thought I'd just share in particular what our pharmacists do at CAMH. We have a number of addiction-focused services at CAMH, and our pharmacists practice in both inpatient and outpatient settings. They, in those settings, they practice what we in the profession call pharmaceutical care, which involves doing fulsome assessments on patients, taking good medication histories, finding out past responses, past medication tried, as well as all of their current medications and their experience with those medications, including whether they feel it's working, drug interactions, assessing the dose, too high, too low, that type of thing. From this assessment, then, pharmacists then identify any drug therapy problems and make recommendations to patients and teams, working with the patients in particular, getting sort of a client-centered approach in what will work best. And also then involved with monitoring and follow-up, both medication use and the clinical outcomes. Are they achieving what we want them to achieve, as well as supporting medication education? And so our pharmacists do this as members of an interprofessional team. And also they're involved in more broadly at CAMH by helping with their addiction specialty knowledge in consultations as well as capacity building elsewhere at the center. They're also involved with some ECHO programs in the province, serving as hub members for the addiction medicine ECHO, Project ECHO, as well as the chronic pain and opioid stewardship program. And of course, as an academic center, our pharmacists are involved with both CAMH education programs and U of T course teaching and supervising pharmacy students and also some research. On this slide, I just wanted to kind of give a snapshot of different papers that have been published around pharmacists' role, especially recently, and some of the attention, particularly in the US, around trying to leverage the role of community pharmacists. And so these papers kind of talk about the pharmacist's role in different settings, from ED pharmacists helping patients start buprenorphine, to using clinical pharmacy specialists to help promote and integrate opioid use disorder services in primary care settings, to a pharmacist's role in prevention through opioid stewardship activities, for example. One of these papers you'll see on the top left is actually one describing a role of that was developed at CAMH. And this paper was written by a couple of our addiction pharmacists, Tiana Costa and Maria Zhang, looking specifically at a role around opioid overdose prevention, where the pharmacists developed educational materials and did a lot of training around the center for staff, clients, families, public, both education, providing naloxone kits, etc. And it's described in this paper. So this is just kind of to set the scene around that there's been a lot of interest in this. A number of these papers were from a special issue in the American Journal of Health System Pharmacists. But we'll be focusing now more specifically on community pharmacy as we go forward. So to kind of prepare for this talk, we sought input from community pharmacists to get an idea of what their thoughts were around any challenges or thoughts they have around providing services for OAT from their community setting. And these pharmacists came from different parts of the province, but I would say that this slide summarizes the general themes in the feedback that we got from these few pharmacists. So certainly communication was key, and communication was seen as a major barrier in providing optimal care. Prescribers were hard to reach and may not call back. Sort of managing the fact that practice varies amongst prescribers, even amongst prescribers in the same clinics, as was described. And it really kind of raises the question for pharmacists, and some of the concerns they raised was they're not sure whether the changes that they may see in prescriptions or unusual prescriptions, was this unintended, or is it due to the newer recommendations that are coming out, for example, related to fentanyl users, or due to the pandemic guidance. And so really feeling that, recognizing that this may cause some delays that are distressing for patients, and but also found, said that most prescribers do have a collaborative approach, like once you're able to reach them. So we're going to expand a little bit more on this, and we're going to, Kenny in particular is going to now describe sort of pharmacy practice to kind of help people see, what's going on from the community pharmacy side of things to help with this, both understanding what's going on as well as to help be able to perhaps come up with ideas on how we can improve collaboration in care.
Thanks, Beth. So as Beth had mentioned, my goal in this section is to explain the role of community pharmacists in the provision of addiction treatment, and to highlight some of the challenges community pharmacists face while providing patient care. And then this will also hopefully help explain why some of these concerns were brought up by the other pharmacists, and help set the stage for addressing them later on. Okay. As Beth had mentioned earlier, similar to pharmacists in other clinical settings, community pharmacists play a role in the provision of clinical care for their patients, but they're also responsible for dispensing of the medication for outpatients, where medication is an integral part of that care plan for the patient. When it comes to clinical care, in the context of opioid use disorder, assessing the appropriateness of the dose is a critical role for the community pharmacist. Appropriateness of dose is based on an assessment of what we know about the patient's history with opioids. This includes a longer-term history that the patient would have discussed with the prescriber to inform the initial care plan, but also includes a recent history that might warrant changes to that care plan, such as missed doses, new medications that might interact with opioid therapy, or extraneous prescribing of controlled substances that might be identified through the narcotic monitoring system. Community pharmacists are largely responsible for witnessing that doses are ingested, for monitoring of compliance and preventing diversion. And part of witness dosing includes an assessment of the patient's current status to ensure that that dose can be safely ingested at that time. Pharmacists also play a role in educating patients about their medications, to improve autonomy and informed consent, and to reinforce the goals of therapy. And then pharmacists ensure that patients understand the risks and responsibilities of medication carries and that they have a safe place to store them when they leave the store. With these roles, the community pharmacist acts as the final safety net to ensure that the medication can and will be taken safely and appropriately. Or in other words, the pharmacist is responsible for ensuring that the above conditions have been met before dispensing the medication. Moving on to the right column here, pharmacists also provide clinical care to these patients from a wider lens that is not necessarily focused on the dispensing of a medication at that particular time. This includes things like communicating concerns to the prescriber, such as missed doses or unusual behavior, provision of harm reduction services, such as dispensing naloxone kits, ensuring continuity of care, which might include reminding the patient of upcoming appointments, sending reauthorization requests to the prescriber, or potentially, given the current authority granted to pharmacists as part of the pandemic response, independently adapting or renewing prescriptions for opioids. Because the patient visits the pharmacy frequently, the pharmacist is also ideally situated to monitor and address patient care issues for non-opioid use disorder conditions, and helps to coordinate care between the specialist and the primary care provider. So, as previously mentioned, community pharmacists are also responsible for dispensing the actual medication to the patient. Some of the roles of the pharmacist related to dispensing include product selection, and especially management of that prescription when there are temporary shortages, such as when the pharmacy doesn't stock a particular product, or long-term shortages when there's a disruption in the supply chain and then that product is on back order. The pharmacy might prepare the medication in special packaging to improve safety or compliance, such as blister packs to facilitate dose titration when microdosing buprenorphine. The pharmacy submits claims for the medication for the purposes of payment, but also for record keeping, such as in the case of the narcotic monitoring system. And the pharmacy is expected to have measures in place to identify and safeguard against prescription forgeries, as per legislation and standards of practice. So just kind of quickly summarizing, in an ideal situation, this process of doing the clinical check and dispensing the medication is straightforward, and the medication is dispensed to the patient safely and efficiently. Okay. And to help reinforce the importance of these roles of community pharmacists, this slide includes some excerpts from the standards of practice adopted by the Ontario College of Pharmacists. So pharmacists must independently review each prescription to ensure that the medication is the most appropriate for the specific patient and that the dose and instructions for use are correct, rectify prescriptions that pose risks to a patient, and assess the appropriateness of refills. So there is an expectation from the college and therefore from the public that pharmacists are fulfilling the roles that we discussed previously. Okay, barriers. So as I mentioned, dispensing medication is relatively straightforward in an ideal situation. And now we're going to discuss some of the barriers to this ideal situation that community pharmacies face, and hopefully illuminate some of the challenges pharmacists have when providing care for patients with opioid use disorder. But before we dive into them, we've provided a couple of scenarios that are not atypical in community pharmacy that might help exemplify some of these barriers. So in this first scenario, we have a pharmacist who is working a relief shift. So that means they're relatively unfamiliar with the pharmacy in which they're working, at a 24-hour pharmacy, and is currently working alone in the dispensary. A prescription had been faxed into the pharmacy earlier in the day, but had not been inspected closely until the patient arrives at the pharmacy at 11 p.m. The prescription is for a witnessed high dose of Schramm for 1 day only, as the patient is visiting from out of town. The pharmacist is unfamiliar with the patient and the prescriber, and the patient's previous pharmacy is now closed. So now what? The pharmacist needs to come up with some sort of plan to manage this patient's care, but there are definitely some barriers there to doing so effectively. And we'll revisit this case a little bit later in the presentation. So there's a second scenario here. So a patient had an appointment at an outpatient clinic setting where a plan was established to initiate observed doses of buprenorphine at the community pharmacy. The pharmacy receives the prescription, but then the patient doesn't present to the store. The patient calls the pharmacy later in the day to inform them that sometime after the appointment with the clinic, the patient was ordered to isolate due to exposure to COVID-19 and is now requesting a delivery of the buprenorphine. The prescriber's clinic is now closed. So what can the pharmacist do at this point? And again, think about this, but we'll revisit this case a little bit later in the presentation. So now, let's articulate the barriers to patient care seen in community pharmacy, some of which were illustrated in the previous scenarios. First off, there are some barriers surrounding community pharmacy as an organization. And I think the most important one to highlight here is that prescriptions are received by a pharmacy and not by any particular pharmacist. So while prescribers may have established relationships with the pharmacy, it's the particular pharmacist on duty at the time when the patient presents who is responsible for the safe and appropriate dispensing of that medication. This pharmacist does not necessarily have any established relationship with the pharmacy. So for example, the pharmacist might work on a casual basis or might even be working only that one shift as a relief pharmacist. In a pharmacy that is open 24/7, it would not be unusual to have many part-time pharmacists on the roster to ensure adequate coverage throughout the week. Next, the success of handing off patient care between pharmacists varies widely by pharmacy and by individual pharmacist. And there are a lot of reasons for that, but one of the big ones is that our pharmacy management systems that we use to keep track of our prescriptions, they were traditionally structured to manage billing and movement of a product, so having a product-centered focus, and not to retain notes for clinical care. Given the complexity of documentation requirements for patients with opioid use disorder, our pharmacy software is often inadequate for this purpose. So every pharmacy must come up with their own system for managing clinical notes. And this system gets harder to manage as the staff and number of patients grows. Another barrier is that community pharmacy is generally not an appointment-based service. So it is difficult to ensure that the pharmacy has adequate staffing to provide the necessary services in an effective fashion. Every pharmacy has had its moments where all the patients seem to show up all at the same time, and all of them are vying for the pharmacist's attention. And these situations add pressure that might affect the quality of patient care. There are also sometimes unanticipated surges in demand for a product that can lead to delays, such as multiple urgent prescriptions for depot buprenorphine arriving at the same time, where supply in the pharmacy is usually limited and restocking may take several days. Okay, as a bit of an aside, I quickly want to illustrate an example of how compensation at the pharmacy level for some of these barriers can have unintended consequences for patient care provided by other practitioners. So as I mentioned, community pharmacy is generally not an appointment-based service. To help mitigate the burden of workload surges on pharmacy staff, pharmacies will often process and prepare medications in advance during slower periods. This results in a discrepancy between the time that the medication was processed and the time of dispensing. For opioid use disorder, where the time of dispensing or ingestion is important for clinical care, the pharmacies that prepare medications in advance should have some internal means of documenting the time of dispensing. However, claims are submitted to the ministry during the processing stage. So the unintended consequence here is that if other practitioners are using claims data to guide decisions regarding patient care, those claims are not an accurate measure of when the patient received the medication because the internal pharmacy documentation is not passed along with those claims. Before we move on to other ones, just wrapping up with organizational barriers here. It's important to note that patients also have the freedom to choose where they have their medications dispensed. So even if one particular pharmacy has good established relationships with their prescribers and their staff and has implemented policies to ensure internal consistency of care, there is no guarantee that the patient will consistently use that pharmacy. And this can unfortunately lead to fragmenting of care, and any of the pharmacies involved may have their own difficulties overcoming these organizational barriers. Okay, looking at the top right now, there are some knowledge barriers to providing addiction services. And the important one here is that community pharmacists are generalists by nature. So every pharmacist will have a varying degree of knowledge and experience and comfort level in any therapeutic area. It is important to recognize that community pharmacists will likely not have the same knowledge base and expertise in opioid use disorders as a practitioner that specializes in it. So there is probably a knowledge gap here that should be acknowledged when working with community pharmacists. Moving down here to the bottom left, from a system standpoint, pharmacists often have access to very little information that has already been generated about a patient. So most pharmacies do not have access to lab results. They will not have access to the prescriber's notes or care plan or anything else in the patient's charts outside of the pharmacy that might be relevant to making clinical decisions. And so the pharmacists often have to dispense medication safely and appropriately based solely on patient report, even though other information has likely been collected and is just unavailable to them. Along the same lines, pharmacists often report difficulty contacting prescribers when needed to clarify prescriptions or care plans, or to request more information about the patient. And it is especially difficult to contact prescribers in a timely manner for urgent situations. Okay, moving on to the bottom right. Therapy for opioid use disorder presents with some unique barriers to patient care. So opioids have, as we all know, have a narrow therapeutic range, and that range has wide interpersonal variation. Dosing a patient outside of that therapeutic range can potentially lead to severe consequences for that patient. So while a lack of information is an issue for all medications in community pharmacy, it is particularly so for opioids because an assessment of the safety and appropriateness of a dose requires knowledge of the patient's opioid history. There's also a time-dependent nature or greater urgency when it comes to decision-making for opioid use disorder. Because opioid therapy is often dispensed daily, any issues that arise must be addressed immediately to avoid disruptions in the patient's care. So ultimately, the pharmacist has to use professional judgment to determine if a prescription is appropriate to dispense. If the pharmacist does not have the right combination of patient rapport, reliable information, and clinical experience, then the plan determined by the pharmacist may be at odds with the plan intended by the prescriber and may lead to less than ideal outcomes for the patient. Okay, moving along, I'm going to discuss some of the values of collaboration in opioid use disorder. So I don't think anyone would argue that there's no value to collaboration in the healthcare setting. In the context of opioid use disorder, collaboration helps to remove or mitigate the barriers to provision of care that we just discussed, to enable pharmacists to make clinical decisions that are in the best interest of their patients. Some of these collaborative practices include sharing of patient-specific history that is relevant to the patient's therapy, and sharing of the care plan and goals of therapy, so that the pharmacist has a richer body of knowledge from which to base clinical decisions. And may also include the sharing of best practices specific to opioid use disorder, so that the pharmacist has a stronger skill set with which to work that more closely aligns with the practice of the prescriber. So collaboration strengthens the relationship between care providers. And the hope is that the relationship leads to better communication between parties, including the sharing of information in both directions, a better understanding of each other's roles and their limitations, which will help identify weaknesses in the system that may prompt the need for a collaborative solution, as briefly illustrated in the example with the prescriptions process in advance of the patient's arrival, and a better understanding of how information is used by different providers. So the quality of information reporting should improve when the reporting provider understands how that information will be used by the receiver. The overall goal of collaboration is, of course, to improve the quality of patient care. And it's important not to forget that we are all working, perhaps with different lenses, towards a common goal, which is the improvement of health for our patients.
Okay, so in speaking about collaboration, I thought it might be helpful to show this study that was conducted in the US, but it shows the communication experiences between buprenorphine prescribers and community pharmacists as a qualitative study. So what they did was look at 10 prescribers and conducted interviews about their sort of communication and interactions with community pharmacies. So in the US, it's a little bit different. These are prescribers who are allowed to prescribe buprenorphine outside of a more formal opioid treatment program. And so it's kind of a newer model where, relatively compared to Canada, where community pharmacists were providing this service. But I think how they've described their results is kind of useful in framing our discussion as well. So I just have a couple of slides where they've summarized the key points around communication. So they highlight that there is indirect and direct communication between prescribers and pharmacists. And one of the quotes was, my communication with the pharmacist is occasionally a conversation. More often than not, it's either through my nurse or through the patient themselves. And I think we can definitely kind of see that here as well, where it's often sort of third party, and pharmacists generally get most of their information from the patient about prescriptions. Also, related to communication, they describe sort of a reactive versus proactive communication. And in this quote, it's kind of describing the more proactive communication where we've taken to contacting the pharmacist when I have a new patient that says they're going to get their prescription filled there. And we're usually able to work something out. They also identified themes related to role expectations. And so with respect to prescription processes, most pharmacists stated that the primary role of the community pharmacist was to dispense the medication or to ensure that the buprenorphine prescription gets filled. So you can see how that's a little bit at odds with what professional responsibilities pharmacists actually have. That is definitely part of the role, for sure. As well as the role expectations related to patient care, it's kind of a similar theme where they summarize the results in that the physician roles were very patient care focused, patient education about buprenorphine side effects, and providing non-judgmental care. And that they felt that the appropriate use of the term collaboration is to facilitate my prescribing medications, which I'm board certified to prescribe. So again, the prescribers feeling that, that they perhaps shouldn't be questioned, that pharmacists should just fill the prescription. So not examples of sort of good communication there. And I think part of it had to do with what they summarize as the climate of clinical practice here. And this is where stigma theme came up, where these prescribers had the perception that many community pharmacists hold stigmatizing attitudes towards opioid use disorder treatment and negative judgments about prescribers in clinics. And I see that there's a comment in the chat already related to this. And yeah, unfortunately, yes, stigma is definitely a problem in our society, as well as with healthcare providers, and pharmacists are no exception. And we need to do more to really help combat those stigmatizing attitudes and treatments. We know it kind of shows up in different ways, whether they may be treated differently in the pharmacy or more overtly. So definitely an issue that was, and I think it's more of a problem in the U.S., but definitely here as well. And we've heard similar kind of problems here. And then the other piece around the climate of clinical practice is just the issue of time, that they recognize that both professionals are busy, and so time is a barrier. And I really think that is important, because certainly when you're trying to communicate and collaborate, taking the time to do that can sometimes be problematic or difficult to do. I also wanted to share another study, which is a little bit different, but it's also on this theme of collaboration. And since it was a very recent study published in Addiction just this year, they again looked at this buprenorphine physician-pharmacist kind of collaboration, but conducted a open-label feasibility trial of a new model, or a different model around physician-pharmacist collaboration. And the goal really was to help address a shortage of buprenorphine prescribers and to help improve care. And so this was not randomized, but it was a single-arm, open-label feasibility trial where they enrolled 3 buprenorphine treatment clinics involving 6 physicians and 3 community pharmacies involving 6 pharmacists. And this took place in North Carolina. So the overall model of care was that patients receiving buprenorphine had their care transferred from the physician to the pharmacist for 6 months. And the paper had a useful figure, I think, that kind of compared the model, the usual care model, to what the collaborative care model is that they're using in this study. So on the usual care side, you can see that it kind of reflects what we were talking about, where you've got the patient that interacts with the physician, and the patient interacts with the pharmacist, and sometimes the physician and pharmacist interact. And the model is that it's the prescriber that's providing the care, and the patient is visiting the physician, regularly, and then the patient sees the pharmacist to get the prescription filled. And communication between physicians and pharmacists, take place about the prescription as needed. With the physician-pharmacist collaborative care model, it's more of a team-based care that the team interacts with the patient. And in this model, the care is kind of transferred to the pharmacist, so that the patients who are stabilized on buprenorphine then saw the pharmacist regularly. The physician would be sort of collaborate with the pharmacist on the patient's care, making sure that the goals and clinical guidance was there. But the patient sees the pharmacist regularly and sees the physician as needed. And the physician and pharmacist communicate regularly about the patient's progress. So just a little bit about methods of how they actually made this work was that the the pharmacists received 6 hours of training modules about opioid use disorder and buprenorphine treatment, plus 8 hours of face-to-face coaching by study physicians around opioid use disorder care, but also around kind of study processes, etc. The patients who were involved, as I mentioned, were stabilized on buprenorphine. They'd been on the same dose for at least 3 weeks, but had been in care for less than 12 months. And they specifically excluded those who had more complex clinical pictures. So the results of the study were that most patients who were eligible went ahead and enrolled. They had high rates of treatment retention and adherence, and there were no opioid-related safety events. And over 90% of the patients endorsed being very satisfied with their experience and the quality of treatment, that the treatment transfer was quite not difficult at all, and that holding buprenorphine visits at the same place that the medication is dispensed was very or extremely useful or convenient. And had similarly positive ratings amongst the physicians and the pharmacists. So I think that, this was not meant to kind of promote or suggest that this is kind of a model that we should have here, but I think it kind of illustrates some of the benefits or some of the things that could happen with kind of more structured collaborative care amongst prescribers and pharmacists. And I just wanted to highlight that the recommendations around improving communication and collaboration aren't new. This is showing a document that we created almost a dozen years ago, which is why it focuses on methadone prior to the more widespread use of buprenorphine, where in addition to the clinical guide that we create at CAMH for pharmacists practicing with opioid agonist therapy, we put out this document that was more related to broader issues around providing pharmacist services and was targeting, also kind of pharmacy managers, owners, corporates, etc. But I just want to highlight that, one of the recommendations was that prescribing physicians and MMT programs establish and then maintain communication with community pharmacists regarding client treatment plans and progress. And then more specifically, that at least initial contact between the physician and pharmacist should include a discussion about the client's needs. For example, other health issues, other substance use, concurrent disorders, and that for shared care to work, the team members should develop suitable ways of sharing information for assessments and treatment planning and for communicating any clinical feedback. So really opening up those communication channels. And I just want to emphasize that, what we've been discussing so far is kind of, what the situation in general and what's been, how practice is. But what's complicated it now in particular is obviously the landscape at the moment around with the opioid crisis, with the pandemic, with changing guidances and approaches to managing opioid use disorder, in particular using medications to manage opioid use disorder. So we still have the OAT pandemic guidance, and a big question is going to be, should that, the recommendations around take-home doses be continued or walked back after the pandemic. Of course, a big one is the CPSO rescinding their standards and guidelines, which is really what kind of ruled practice for methadone in the province, and which was what's been taught to most practitioners out there as a requirement for providing services, and which is leaving a lot of questions at the moment and a bit of a gap right now, where we won't have those same kind of rules to guide practice and to fall back on. And then, of course, there's the new evolving recommendations coming out, for example, Metaphyse, methadone for fentanyl users. But also there is a new national guideline that has been coordinated through CAMH, but was really created in conjunction with medical regulatory authorities from across the country. That's where the expert reviewers were coming from, and it's sort of a synthesis of the different provincial guidelines that have been out there to come up with a new national guideline. So it's different from, you may be familiar with the CRISM guidelines that were quite high level and kind of recommended, when to choose which drug, buprenorphine over methadone, that type of thing. whereas these guidelines are more in line with CPSO in providing kind of actual approaches to care and initial dosing and these types of things, but much less prescriptive, much more open to clinical judgment, providing guidance around what to be considering and thinking about in providing care, and very much a patient-centered kind of language and focus. And they will be coming out literally any day now. They'll be launched, so we'll keep an eye out for that. But then also the practice changes themselves that are happening at the moment with buprenorphine microdosing, the new buprenorphine formulations, injectable formulations, the enhanced role of slow-release oral morphine in this space, the need for more injectable OAT options, and the expansion of safer supply programs. This is all new for practitioners in all settings and is evolving. So really, the bottom line is that the more communication amongst care providers, the better.
Okay, so given some of the more common issues that come up in community pharmacy, we suggested some actions that help foster collaboration between prescribers and pharmacists. So this slide lists some general actions that may help address issues with particular prescriptions. And these actions include communicating proactively with the pharmacy at critical points of care, or those situations where the pharmacist is more likely to have questions or seek clarification about prescriptions. These situations include new starts to therapy or a new pharmacy for an existing patient, dose changes, additional carries, either a temporary increase for special circumstances or a long-term increase to carries, and temporary pharmacy changes, as might be the case if the usual pharmacy is closed for a holiday or the patient is going out of town. It is helpful to outline channels of communication in the event that the pharmacist does need input from the prescriber. For example, during business hours, is there an alternative phone line the pharmacist can call to avoid waiting in the public queue? Or is there an on-call service that can be accessed outside of business hours? It is important to set expectations between all parties so that everyone is on the same page. For example, if the clinic does not have an on-call service, what level of responsibility rests with the patient for managing their own care when urgent issues arise? Is it appropriate for the pharmacist to seek an after-hours consult from the prescriber for certain situations like last-minute travel plans? Is there any sort of formal agreement between the prescriber and the patient that can be shared with the pharmacy? And then this slide lists some actions that can help improve collaboration with established pharmacists or pharmacies in the long term. These actions include learning more about the pharmacy team, such as the number of pharmacists who work there and how often. And similarly, might be helpful to provide an introduction to your practice so that the pharmacy has a better understanding of who may be involved in the patient's care. Extend invitations to continuing education events. So continuing education helps fortify the pharmacist's knowledge and skills in opioid use disorder, helps align standards of practice across care settings, and potentially provides an opportunity for practitioners to meet face-to-face, either virtually or otherwise. Extend invitations to discussion of policy. So when developing policies that relate to medications, consider seeking input from a pharmacy partner. The pharmacist can provide a new perspective or offer new solutions to medication issues. They can identify incorrect or incomplete assumptions about pharmacy practice that might impact the utility of the policy. And the pharmacy partner will leave with a greater understanding of how pharmacy practice impacts the clinic operations. Hold a town hall. There are likely many prescribers and pharmacists involved in providing care to any given community. It may be prudent and more efficient to gather everyone together to discuss common and ongoing issues so that there is a general consensus of values within the group, as opposed to everyone trying to build relationships in a pairwise fashion. Collaborate to create standardized forms for reporting common information. This is an exercise in understanding what information is available, what information is desired, and how that information can be shared between providers in an efficient manner that is not onerous for either party. Acknowledge that you've received communication from the pharmacy. So pharmacists are more likely to perceive value in communication and therefore more likely to send it if they can see how that communication contributes to patient care. Acknowledgement provides a feedback loop that reinforces the importance of the provided information. For example, a simple note might read, thanks for the note regarding missed doses, no changes to therapy at this time. Finally, have a discussion to review cases when there are disruptions to patient care. So try as we might, we cannot account for all possible scenarios. So there will likely be some unavoidable disruptions to patient care. Having a debrief of the situation with the involved parties can help to identify previously unidentified weaknesses in the system and provides an opportunity to collaborate on a solution for preventing the disruption from occurring again in the future. So now we're going to revisit the scenarios that we had mentioned earlier and see what collaborative practices might have helped the pharmacist formulate an informed plan for the patient. So scenario A involved the patient visiting a 24-hour pharmacy out of town for a one-time dose of Shram. In this case, the prescriber could have identified this as a critical point in the patient's care because the new pharmacy is unlikely to have any patient-specific information that would be desired when formulating a care plan. The prescriber could have preemptively called the pharmacy to confirm the authenticity of the prescription, to provide the pharmacist with any relevant patient history, and address any concerns the pharmacist may have regarding that prescription. Scenario B involved the patient who was supposed to initiate witness dosing of buprenorphine in the pharmacy, but is now in isolation and cannot present to the store. So this case involves some unusual circumstances that warrant formulating a new care plan for that patient. Again, the prescriber could have identified this as a critical point and called the pharmacy preemptively to provide the patient history that would help the pharmacist make an informed decision. If the clinic had an on-call service, the pharmacist could call the prescriber to collaboratively create a new plan that aligns with the prescriber's values. But otherwise, the pharmacist would have to use whatever information is available at the time to independently devise a new plan, which may or may not align with the prescriber's practices.
Okay, so we're just nearing the end now and wanted to summarize with the key messages that we really want to leave you with tonight. So in case you missed it, communication and collaboration is really needed now more than ever with the opioid crisis, the pandemic, with the evolution in these models of care. But we know that uptake of practice changes can be slow and difficult. We know that kind of that knowledge translation piece or the development of evidence and then implementing it into practice is traditionally a very long process. And I think we really need to be thinking about how we could speed up that process in this particular case, just because of the nature of what's happening and the severe consequences. For this to happen, I think we need sort of both effort and action by both prescribers and pharmacists to try and improve communication and really reduce some of these barriers and issues. And from a pharmacy perspective, we have been working on this and seeing how we can help with communications to pharmacists about these changing guidance documents and models of care. to be both in, at least in the last 10 or 11 years. It's only been in the last 10 or 11 years, I guess I should say, that that there was core addictions related content in the undergraduate pharmacy programs, which means that most pharmacists out there did not get introduced this in their training and have needed to learn subsequently. And we have changed that in the curriculum now, but there's still, a lot of support, I think, that pharmacists could use in working in this area, and we're trying to rectify that. In addition, we have some research going, and I just wanted to mention this as the last slide, where really trying to see what's going on right now with respect to pharmacy services for opioid use disorder, to be able to help the guide, sort of forward actions. We were able to get a CIHR grant to look at questions around what was happening with pharmacy practice, specifically during the pandemic, to assess the changes in current state, to be able to, more formally identify these types of issues and challenges, but also specifically to develop best practice guidance for pharmacists and to make recommendations for pharmacist services going forward. What can we improve or advance or expand in our care? So the research team is from people from CAMH, from Institute of Safe Medication Practices and U of T. The project has a number of studies, including stakeholder interviews with people with opioid use disorder and prescribers, for example. And we also have a citizens panel who is serving as advisory throughout, to really help us determine what's important. And so hopefully we'll stay posted on that, and we may have some, hopefully in the future, be able to help guide and support pharmacists even more. Thank you.
Thank you so much. I think lots of questions. I guess I want to start with, what are your answers to scenario A and B? And how do you see those playing out? Can you take us back to those?
Sure, let's pull this up.
I guess my one question is, you said something about a high dose of SROM.
Right.
What would be a high dose? And I'm not trying to be provocative, but just a question. And because I guess because of the ways that that SROM is used in OHT and the sort of contradictions built into the doses that we use for OHT versus the chronic pain guidelines and the much lower doses of opioids used for pain management typically.
Right. So I think great question, and I think that when I was writing, just jotting down the scenario, I intentionally left it kind of vague because the perception of a high dose really depends on, I would say, the pharmacist who's receiving that prescription and what their experience is with that medication and what they know about that patient as well, right? So if you have a pharmacy that is not necessarily familiar with opioid use disorder, there are a lot of conflicting guidelines, and some of them were kind of hammered in a little bit better than others. So looking at just opioids for chronic non-cancer pain, anything that's above that, let's say 50 milli morphine equivalent dose might be considered high, versus other pharmacies or pharmacists that have more tolerant or more experience with opioid use disorders, that high dose might be something different. So, I mean, I think when I was writing this, something that would be alarming for somebody who is not familiar with that patient, even though you might have an understanding of opioid use disorder. So, I mean, 900, let's say, where it might be acceptable for some people, but could be lethal for others. So, what would you do in this situation? I know we didn't really answer it, and I mean, it's because there are so many variables involved in what kind of information that pharmacists can do or can gather, and what comfort level they have with managing these opioids. And I think this might be one of those cases if that pharmacist is not able to to retrieve any additional information about that patient or gain some sort of confidence in the reliability of the information that the patient is providing, I think this would be a scenario where the pharmacist might really not be comfortable dispensing that medication, and that patient would miss a dose. And important to note that, I mean, it's not that the pharmacist has any intention of disrupting that care plan that was already established for that patient. It's that given that information that's available to the patient at that time, that is the plan that the pharmacist came up that is in the best interest of the patient, as far as I know.
So how would access to Connecting Ontario potentially help you? How often is that used? How often do you find inaccuracies, which I know is a concern for physicians who are, working in the emergency department, for example, and don't find it particularly reliable all the time?
For sure, and I mean that we alluded a little bit to that in this scenario where, I mean, the use of claims data to guide clinical decisions. I mean, I don't think it was ever an intended function of that system. It was more about collecting. I mean, it was initially about claims data, and there are some things built into there. We can cancel things further in advance if the patient doesn't pick up the medication. So there's some nuances about it that need to be understood if using it for clinical purposes. I think right now, I'm not quite sure how many pharmacies are connected to Connecting Ontario. I mean, our pharmacy is, but I know that we are an exception rather than the rule.
Or NMS, if that's what you're more likely connected to. Is that
Sorry,
or NMS or DHDR?
So NMS, it's mandatory. So all pharmacies are connected to NMS, but the alerts that you'll get from NMS are not necessarily informative. And I mean, in something like this, in this case, there would likely be no alert from NMS if the patient had been using one pharmacy regularly, one prescriber. So that the receiving pharmacy here would not receive any useful information from NMS at that time. Connecting Ontario, I think pharmacies might have a better understanding of where some of those pitfalls are with respect to claims data. So I think we would be more proactive in trying to contact other pharmacies just to verify information, because there's the understanding there that some of that claims data may not be accurate. In this case, I mean, if you have nothing else to go on, and you can't connect to anyone because everyone else is closed, but you do have access to Connecting Ontario, if it corroborates the patient's report, then it would be up to the pharmacist's judgment whether or not to trust that claims data without having to or being able to verify it with the pharmacy.
So in this kind of scenario, I guess ideal would be if the physician or the prescriber called the pharmacy to say this patient is coming to guest dose, thank you, at least wrote on the prescription, thank you for guest dosing, and potentially advised the patient to take a receipt from their usual pharmacy confirming previous dose, which is what we have learned, I think, many of us, to advise patients so that they can confirm.
For sure. I mean, even with the best of intentions, there's all sorts of reasons why some of those things might not happen, right? So again, it's using the information that's available to come up with the best possible plan for that patient at that point in time.
Okay. You could have an unhappy patient, but on the other hand, you might potentially be protecting someone.
Right.
Fair. Yeah.
And then scenario B. So this is, I mean, so some potential solutions here. The concern here is that the patient can't present to the pharmacy for other reasons. And so is there some other way to do an observed dose of buprenorphine, or does the pharmacist think that it might be okay to dispense the buprenorphine without observing it? And I mean, I think there are some. I guess it's also relevant that it's a new start, so the patient actually hasn't started yet the buprenorphine. So I mean, there are a lot of potential solutions here. You might be able to delay start until the patient can come to do observed dosing. There might be some other way, and I think this is in the pandemic guidelines, some other way to do the observation that remotely. So I mean, some sort of maybe like a Zoom call, something similar to video conferencing, but difficulty there as well with respect to COVID exposure and keeping whoever's holding that device safe. Or is it okay to just dispense the medication without having the observed dose? And again, this would depend on the pharmacist's comfort level with managing opioid use disorder, what other information they're able to gather about that patient, perhaps what they know about the prescriber and the prescriber's practice, and maybe perhaps some of the prescriber's preferences from previous patients to help guide those decisions. But I mean, the understanding here is that once again, the pharmacist has to come up with some sort of plan using the information that's available, and it might not necessarily be the same plan that the prescriber would have come up with if they had the opportunity to be involved.
Yeah, for me, that one feels less complicated, I would say, because I'm not attached anymore to someone watching the buprenorphine dissolve sublingually and checking someone's mouth. I think that there are very good reasons, pre-pandemic, and then for me, thankfully, reinforced by pandemic changes, that we don't need to do that. So I would imagine that there are different delivery scenarios. The important thing is instructing someone about how it has to be taken. In my mind, not observing that they've, taken it and that it's dissolved. So, but I appreciate what you're saying, and waiting till they come in is definitely not a good option when that's 14 days away, potentially. So there does need to be some problem solving there. I'm going to go back to the beginning to ask some questions in a minute from the questions that were posted earlier, but there's another question about if you're a community pharmacist without access to Connecting Ontario, the question is, if I'm not familiar with what information can be gathered, if the patient is not covered by Ontario Works or ODSP, what shows up on Connecting Ontario? So maybe like a quick kind of primer about the resources. And I don't think either one of you mentioned DHDR, the Drug Health Data Repository Center, which I thought was going to be another way for us all to be able to actually kind of share information.
Yeah, so just to clarify that they're all connected. You're all talking about the same thing, really. So the NMS data that's available through Connecting Ontario, for example, is it's available through Connecting Ontario because it's part of the DHDR. So that the DHDR comprises of all the NMS data plus ODB data, claims data. And so why that's important is because pharmacists and pharmacy systems don't have access to NMS data otherwise. It's not, I think that's a misconception a lot of people have, because that is the case in a lot of other provinces where they do have access to their prescription monitoring program data and physicians as well at time of care. That's not the case here. They just get alerts, and the alerts are only if somebody's getting an NMS product from 3 different physicians within 28 days or 3 different pharmacies from 28 days. So it's not actually double doctoring, and I think a lot of people are confused about that as well. But the DHDR basically is a repository for NMS data, for ODB data, and that's available through Connecting Ontario and through Clinical Connect, those 2 systems.
So to that specific question, all medications for someone on ODB or Ontario Works will show up, but for people not on those supports, then it will be controlled substances only. Is that correct?
That's right. That's right.
Correct.
So all monitored drugs, regardless of payer, exactly, are in the NMS system. Yeah.
Okay, great.
Important to note as well that you won't have information about how that medication was dispensed. So was it an observed dose or did the patient get it as a carry?
Right. And we've found that in trying to check doses, and have also found or heard that some, when a prescription is written for a week, it may be pre-billed, and that doesn't necessarily mean that the patient received the doses that were billed. So it's not enough, obviously, to just check that, even though it's a useful tool.
Right.
I'm going to go back to a question that came up at the beginning from Britt, thinking about how to assist a patient who I assume is missing doses and having a hard time getting back to see a prescriber. So her question is, what if she wants to leave a 30 milligram prescription on file at the pharmacy so that the patient can restart without having to see a clinician and get a new prescription dated for that day. And that's one of the strategies that we've suggested in the methadone guidelines, and we know it's a bit complicated. So how can we make that work practically, and how can we avoid the pharmacist canceling the prescription every time someone misses a first dose? And then I'll come to the second part of that question.
Yeah. Yes. So it is a tough one, and again, this is where the communication piece, I think, could really help. The pharmacist is probably going by the training they received, where the prescription's only valid if it has a start and stop date, and if they need to be reassessed if they've missed or haven't started or missed so many doses, and is being cautious. So I don't know if it's been possible to actually have sort of a conversation with the pharmacist and kind of explain where they're coming from with this particular patient and the needs of that patient, and the importance of, giving them the dose when they show up, but also help the pharmacist provide some parameters for the pharmacists around, if they do just show up and nobody really knows when it is, what are those parameters? The usual thing, make sure they're not intoxicated, or find out what other meds are taking, those kinds of things. But if there is a plan ahead of time and some guidance for the pharmacist in making that decision, then I think it could be worked out. I think it can be worked out. And I think that's a very good example of practice changes that we do need to figure out the best way to support, and also get the word out that, expect these things coming more frequently.
And I think important, I'm not quite sure why, but I get the sense that a lot of pharmacists have this gripping fear about prescriptions for opioids or for narcotics or controlled drugs. And just because there's a lot of legislation and regulations surrounding them. And so there are some people who will focus a lot on that legal aspect of it. And is this a valid prescription? And am I really allowed to do this? Even though there's a conflict there, it might be in the interest of patient care to dispense it, but it's not a legal prescription. And how do I deal with that? So, it's something that does seem to come up fairly often, the way that the prescription is written. And it's unfortunate that holds, or might be the reason why there's a disruption to patient care. What I would recommend here, obviously if the prescriber can have that discussion with the pharmacy to help explain, what the rationale is behind that prescription. What I would maybe do, and I would suggest this, is have the pharmacy write it. Or have the pharmacist write the prescription in a way that that they would be comfortable holding on to it for those purposes, so that when it does come time for that patient to or for that medication to be dispensed to the patient, they would be comfortable doing it from a legal aspect, and then send it back to the prescriber and have the prescriber sign it.
So get them to write the wording that they would be comfortable with utilizing, so you know then it came from them and it can't really be misinterpreted.
Absolutely, yes.
Mm-hmm.
And I see there's also a suggestion about, affixing a clinic note to the prescription to try and help with communication as well.
That's a great idea. I don't think I've ever done that. I don't know if I've even thought of it. And I guess I would wonder a little bit about whether any clinic note was sort of oversharing. But I think that's a really interesting idea. I just want to ask again about the sort of logistics around trying to leave a prescription for 30 milligrams starting dose. So I'm thinking aloud and putting you both a bit on the spot. Could you, for example, to meet the expectations of a starting dose and an end date, a start and an end date, have a start date and a prescription that's good for a month that says, please start this medication at any time in the month and do not discontinue unless the patient has missed, well, I guess it's a starting dose. We don't want it discontinued. We want it started, right? So if you have any suggestions for wording for that, and wording, I know one of the comments that came up was, how many days from the time that prescription is written is it still valid for, and is there a way around that?
I do. I'll start, but Kenny's the one that actually does the hands-on dispensing, so we can see what he thinks. But I think if you put enough wraparound information around that. So as you say, maybe a month is a bit long, but say if you're expecting that this patient, so I don't know whether you're talking about new starts. So if this patient comes when they're ready and they come to your pharmacy within this 2-week period, please dispense this dose of methadone or buprenorphine, and continue that dose for every day they show up, and then in the following week, and they know to contact me to be able to get further dosing, or so that there's some framing around, well, when are they going to be assessed? How long is this going to go for? What are the parameters around, I guess just making it very clear what's expected from the pharmacist from a clinical assessment point of view, as well as, when this needs to go back to the doc for sure. And contingencies in case, something happens.
Yeah. I don't want to belabor it, because I think those are some really good suggestions we need to think about, and maybe sort of create some templates for that. But I do think it's not your typical new start where that would be done, but in someone who's likely been on and off, and we're, really trying to make sure that they stay connected. Second question is, in patients where, for example, they've perhaps been at a higher dose, they've missed doses, they're restarting, and we might want to pre-plan their dose increases. There are different scenarios where that could happen, right? They're restarting at 30, and then we want to go 30, 45, 60, or 30 for 3 days, and then 40. So this is a comment that the pharmacy won't accept a prescription that has a dose increase written on it, that it requires a new prescription. Any thoughts around that? I would agree. I don't think that an automatic dose prescription is probably accepted in Ontario. We've seen different sets of guidelines where, pre-planned dose increases in the first week seem to be part of the guidelines or protocols, but has not been the case here.
I think this is more of a guideline thing, and maybe Beth can talk about this a little bit more. But I mean, this is another one of those things where, like, there's potentially a good reason there, or a good reason that the pharmacist is missing for having the prescription written that way, and again having that perhaps finding out why they're not honoring that and maybe trying to align some of those practices. This is why we're doing it, and here's some rationale. And this is, I think, something I had spoken to earlier about policies, especially if this is something that's done commonly, is have some of those pharmacy partners involved in what are the issues that they're seeing, and can those two viewpoints be aligned a little bit better to come up with a better solution. So I mean, I don't think it should be impossible. I think it just involves a little bit more, perhaps some input from the pharmacy, and again, maybe getting them to write the prescription to make sure that they're comfortable with it.
I also think that this is going to be like a sea change in how this is viewed, because pharmacists traditionally are focused on, is this safe to give? What's going to be the implications of this person taking this dose that I'm giving them? And that's been, focusing on the risks of that opioid. Is it going to be too much? And helping, I think, the framing, for example, that's in the Medify guidelines for methadone for fentanyl users, helping pharmacists frame the risks as not only the risk of giving that opioid, but the significant risks now currently of not giving it and people injecting street fentanyl. And that the risk, the balance is shifted now, depending on the person and the situation, of course. But it's definitely more nuanced, so it's more difficult for everybody. And that's where, again, that communication, collaboration, explaining what's going on, with this patient and why this is critical, and that it's more important to kind of keep them engaged for this reason, will help the pharmacist in making that judgment that they need to make.
Yeah. So obviously there's lots of room for education and improving communication. One of the questions that came up was about education, specifically around stigma. And for pharmacists, I mean, the whole notion of someone having to go into a separate little cubicle at a pharmacy, take their medication, I think is problematic. Same with, looking in someone's mouth. What are your comments on that?
Yeah, I think I think that it's really important, because we know that it is a problem. And that study from Australia that was on one of my slides, where they looked at patients, and one of their key things was they had concerns about privacy and also about being treated differently than other people. As part of that research that I was talking about on the final slide, we recently conducted a pharmacist survey where we had a stigma scale in there too, and I was pleased to see that most pharmacists did not endorse kind of stigmatizing statements. However, there was still a significant proportion that kind of sat on the fence and said they didn't agree or disagree with the statement. And a significant proportion, it's still, if you have 10 or 20% of pharmacists agreeing with some of these statements, it's problematic. So we do have concerns. It's an interesting thought to try and to make some education specifically for pharmacists and help them identify behaviors that they may have that are stigmatizing or that are being perceived that way, and being careful in their speech and that type of thing. There's certainly lots of general resources for healthcare professionals that with CCSA and several resources that we can that we do refer people to. But that's an interesting idea of tailoring it for pharmacy-specific situations. So we can definitely look into that.
Great.
And include that in our cadre of supports, hopefully.
Yeah. There was a question about dispensing fees. And I'm wondering if there are strategies that we can use to help mitigate those costs for people who don't have either private pay benefits or coverage through other provincial programs. It seems to me that there is huge variability in terms of how pharmacies handle this, and the costs between pharmacies, both for methadone and for buprenorphine, even aside from generic versus brand name related issues. And actually, I don't want to forget to ask you about methadose versus methadol D. So I'm just saying that so I don't forget. But go back to the dispensing fees.
Maybe I'll start off here. Although, I mean, again, Beth might have some better resources at her fingertips. Usually, when people come to me, something like coverage has already been established. There are there are some options that should be explored to make sure that all the avenues have been investigated. So Trillium is an important one if it hasn't already been looked at. So anyone can apply for Trillium. What it's supposed to do is cap your out-of-pocket drug payments at a percentage of your net income. So anyone where they are paying a significant proportion out of pocket, that will hopefully be capped at some point. So then the rest of their medication will be provided for by the government. Aside from that, I mean, Beth, any particular or specific programs that you can think of besides?
I don't mean programs. I guess I just mean any strategies for writing prescriptions, or is it really pharmacy specific? Because, and maybe this seems to be, shoppers versus a specialized pharmacy that's seeing lots of people. Is it just within their scope to offer the incentive of not charging a daily dispensing fee?
So I think that is, it's very much a business practice, and you'll have some places, especially, from what I hear, I don't know how much flexibility they have, but chain drugstores like Shoppers, usually they'll have overarching policies that restrict what particular stores are allowed to do. With respect to, it is a business, and there are some free market practices that will be involved in there. So you might find some pharmacies that are more than willing to say, you come here every single day, I will, instead of charging you a dispensing fee every day, I'm going to prorate that over whatever, a couple of weeks or whatnot, to save you on out-of-pocket costs. I don't know. I'm not quite sure if there are any sort of strategies in particular. I think it's really an individual store, whatever their prerogative is, patient care.
There's a question. Do you have any suggestions or resources for pharmacists who are now receiving prescriptions for high doses of non-observed therapy, i.e. Dilaudid tablets, whether or not for injection, I guess, and may be reluctant to dispense due to unfamiliarity with safe supply? That's a bit of a big topic for a few minutes left to go, but you're up for the challenge.
Beth, you go ahead.
I think there's just still a lot that people don't know about safe supply. And I know that some of the providers of safer supply have pre-printed kind of explanations for what this is. And so including that communication, but also actually talking to the person. It comes back to the same thing. It's until these things become more normalized and become more familiar to people, it's going to take some time, especially for things like methadone and buprenorphine. They're associated with OAT. Slow-release oral morphine has been around for a long time, and it's only more recently has gained this significant traction as OAT and also for safer supply programs. And so I think that it's just that there's mixed messaging. One of OCP's, the Ontario College of Pharmacists, quality indicators is not dispensing above 50 MMEs for new starts and these types of things. So there's a lot of mixed messaging that has to be overcome. Now we're saying, in these cases, you may have the high doses. So it's really a matter of working with pharmacists until it becomes more familiar to them. Yeah, and as I say, we are working towards helping with that. We've got an article coming out in OCP, our communication piece from OCP, in the next issue. So hopefully that'll help somewhat.
There's a question here. I'm guessing I know your answer. Do you encourage patients to use the same pharmacy for OAT as for the rest of their meds? I know patients often prefer to keep it separate due to perception of stigma. Is there a greater risk of missing drug interactions and loss of full care? And then a comment that's really distressing, that some pharmacies say that it's in their lease that they are not allowed to dispense OAT.
I can't imagine how that's allowed. That's incredible. Yeah. That is
might be a bit of a scapegoat, unfortunately. I agree. I do agree with the keeping one pharmacy with respect to being able to identify things like drug interactions. I mean, potentially less of a problem as we move forward, as more pharmacies get connected to Connecting Ontario, so that they do have a better history of what patients are on. But I mean, until that happens, I mean, there is obviously going to be better consistency if you're sticking with one pharmacy, you know, with respect to the care, pharmaceutical care.
Mm-hmm. Thanks, everyone. It's 8:30. Yeah, more comments coming up around that in the chat. So I find that really difficult. And I think maybe another education piece, I'm sure Beth, you're already thinking about that, is increasing use of buprenorphine for the treatment of chronic pain.
Yes.
So, you know, if we go through a whole process of explaining why this is a better, safer opioid to transition to for management, and then someone has to go through all over again, you know, being challenged about their quote unquote addiction, that's really difficult. So, thank you. Do we have 1 minute to ask about Metadol D? I've only asked a couple of for changes in prescriptions for a couple of patients, and it's been managed and being very successful. So I don't know whether either of you can quickly add to that.
So not doing well on methadose and doing better on Metadol D, is that the idea?
Yeah.
No idea.
And
yeah.
And in terms of asking a pharmacy, I mean, how complicated is it? What's the big challenge? What's the cost difference? Can you give any on the ground experience there? It seemed straightforward when I asked.
I guess, sorry, what was the context? Like what are some of the issues that come up when I'm trying to do the switch?
When trying to do the switch, just asking the pharmacist to switch to access the Metadol D as opposed to methadose. I know people have commented on the listserv that they've had no, and you know, my experience working with one of the pharmacies was they just said, sure, and next thing I knew. And it's a one-to-one conversion. Subjectively, you know, the person is feeling that their dose is lasting longer and is more effective for them. They had experience being on that before the change to methadose years back, and
I would say, I mean, my guess would be it might be just over, like at a policy level within the pharmacy. So, I mean, this is the product that we carry, and then the prescribers are not being able to contact the right person to who is responsible for overseeing those changes. There might be some concerns with respect to safety if you carry both products and using the wrong one unintentionally, perhaps. But I would say if you're having like a lot of discrepancies with, you know, some people being able to do it and some people not, I would say it's more about being able to speak to the right person.
Okay, so I would say we'll research this. Sorry, Beth, go ahead.
No, I was just going to say one more reason might be if some pharmacies that have larger volumes actually have machines to measure out the product, and they have to be calibrated per product. And so if they're measuring all of their doses using methadose product, then it does become it takes it out of their regular routine to have to switch a product. That's the only thing I could think of from that from a pharmacy lens that might be problematic. Although, you know, I would advocate that they should get in the Metadol D for the care of the patient. Yes.
Okay, so a little bit more research to do there. I'll just say that the patients I have who've switched are not on ODB. They have insurance paying, so I can't speak to it being covered on ODB. Thank you everyone for staying on. I think, you know, as always, there's so much richness in the opportunity to have questions. I'm sure even more so had people been able to not be filtered through me, but thank you. I will ask you please to fill out your evaluations for this program, which I think should be at the top of the screen, although I haven't seen the little red button there, but maybe I missed it. There you go. Click there. Please complete the evaluation. We have had to make a change in our June webinar, and we'll be announcing very shortly topic and speaker, so stay tuned. Put the Medify Conference 2021 in your calendar, September 24th, 25th. And please consider submitting proposals to present at the conference. If you didn't notice our call on the listserv, then take a look at the website and you'll see it there. Thank you, Beth. Thank you, Kenny. Really informative. Lots of things for us to think about in terms of our communication. And I just wish that there was a back line to every pharmacy that I had to call.
And you might be able to get, you know, it's about asking, I think.
Okay, I'm going to ask that. Okay.
Well, thank you for the invitation, Jennifer. Yeah.
Thank you so much.
Okay. Have a great night, everyone.
Thanks, you too.
Thanks.